Hello and welcome to Easy Learning with Dr. Salman. Next is the pathogenesis incubation period. The sporozoite, after gaining entrance into the human body, undergoes a developmental cycle, first in liver and then in the red blood cell. With the commencement of erythrocytic schizogony, the parasite multiplies in geometrical progression and on reaching a sufficient concentration in the blood brings about the onset of fever. This period of development is called the incubation period, which varies with different species. In Plasmodium vivax, Plasmodium ovale and Plasmodium falciparum, it is 10 to 14 days, and in Plasmodium malariae, it is 18 days to 6 weeks. Next is followed by the host response. The disease process in malaria occurs due to the local or systemic response of the host to parasite antigens and tissue hypoxia caused by reduced oxygen delivery because of obstruction of blood flow by the parasitized erythrocytes. Cytokines like TNF, tumor necrosis factor, interleukin-1 and interferon IFN gamma play an important role in the pathogenesis of end organ disease of malaria. These are followed by the pathogenic lesions. These lesions are common to all species except brain lesions, which are seen in Plasmodium falciparum. The pathogenic lesions can be described in these following organs: the spleen, liver, kidneys, brain and the bone marrow. First, the spleen. The spleen functions in malaria as a filter for removing the parasites as well as the product of their schizogony from the bloodstream. The parasites are found in abundance in all stages of development, that is erythrocytic schizogony and gametogony, in the spleen in all forms of malaria, particularly falciparum malaria. Malarial parasites and hematin pigments are actively phagocytosed in the spleen by macrophages, mainly by the cells of Billroth cords, that is the red pulp. In acute infection, the spleen is soft, moderately enlarged and congested, whereas in chronic cases, the spleen does not enlarge as in Kala Azar. It is hard with a thick capsule and slate grey or dark brown or even black in color due to dilated sinusoids, pigment accumulation and fibrosis. Then the liver. The liver is enlarged and congested. Kupffer cells are increased and filled with parasites. Hemozoin pigments are also found in the parenchymal cells. Parenchymal cells show fatty degeneration, atrophy and centrilobular necrosis. Next, the kidneys. Kidneys are enlarged and congested. Glomeruli frequently contain malarial pigments and tubules may contain hemoglobin casts. The renal manifestations in malaria may be divided into two groups. First are those found during an attack of acute falciparum malaria and also in black water fever. This is the renal anoxia syndrome, also known as renal tubular vascular syndrome or lower nephron nephrosis. It is characterized by oliguria or anuria and acute uremia. Second, those found in relapsing cotton malaria resembling nephrotic syndrome. The nephropathy associated with cotton malaria is the result of immunological reaction arising from antigen of Plasmodium malariae and antibody complexes deposited on the glomerular capillary basement membrane. The glomerular injury is caused by complement, that is beta-1 G globulin activation and release of enzymes from the granules of leukocytes. Then brain. The brain in Plasmodium falciparum infection is congested. Capillaries of the brain are plugged with parasitized RBCs. The cut surface of the brain shows slate grey cortex with multiple punctiform hemorrhage in subcortical white matter. These will be discussed more in a separate video on Plasmodium falciparum. Next, the bone marrow. In acute cases, the marrow of the long bones undergoes very little change. In chronic cases, the upper and lower thirds of the long bones are reddish brown in color and may even be slate grey or black. The yellow fatty marrow becomes gradually replaced by the vascular cellular tissue, that is the red formative marrow. There is also decreased erythropoiesis in the bone marrow due to tumor necrosis factor, toxicity and failure of the host to recycle iron bound in hemozoin pigments. So these were the pathogenic lesions. Next, anemia in malaria. After a few paroxysms of fever, normocytic and normochromic anemia develops. Anemia is caused by destruction of large number of red cells by complement-mediated autoimmune hemolysis. Spleen also plays an active role by phagocytic removal of a large number of both infected and uninfected RBCs. Excess removal of uninfected RBCs may account for up to 90% of erythrocyte loss. The causes of anemia in malaria: first, destruction of large number of RBCs by complement-mediated and autoimmune hemolysis. Second, suppression of erythropoiesis in the bone marrow. Third, increased clearance of both parasitized and non-parasitized RBCs by the spleen. Fourth, failure of the host to recycle the iron bound in hemozoin pigment. Fifth, anti-malarial therapy in G6PD deficient patients. If you wish to see more of such videos, do comment below. And don't forget to like, share and subscribe to my channel. Also, press the bell icon for early notification of my new videos.